Welcome to today's webinar titled Home Safety Assessment and Home Modification. My name is Erin Lessert, and I am on staff with the Colorado Department of Public Health and Environment. I'll also be moderating today's webinar and providing you with the support when needed. Today's webinar is the sixth of the Building Community-Based Falls Prevention Programs webinar series. This webinar series was developed by the Colorado Older Adult Falls Prevention Coalition, specifically the Community-Based Older Adult Falls Prevention Team. Many of the members of the team represent hospitals, public health, and other organizations. The team's mission is to reduce the risk of falls through education, raising awareness, advocacy, and improving access to resources. The role of the team is to provide leadership and guidance for local falls prevention efforts. Allow me to introduce presenters for today's webinar. We have Karen Macheco, Trauma Outreach Injury Prevention Coordinator for the Exemplar Good Samaritan Medical Center in Lafayette, Linda Underbrink with the Foothills RETAC Coordinator, Lieutenant Tina Takahashi, EMS Field Coordinator, Westminster Fire Department, Sherry Cabrera, OTR, and Kenna Quiller, VP of Business Development for Hudson Integrative Health Plus Home. One additional note before we get started, you will be able to submit questions at any time throughout the session by submitting them through the questions area of the webinar control panel. After the presentation, we'll have the opportunity to discuss the questions you've submitted. Without further ado, I will pass it over to Karen.
Hi. I'm Karen. I'm from Good Samaritan Hospital and the Foothills RETAC, and today I'm moderating the webinar that's Home Safety Assessment and Modification. And just to run through the previous building blocks, the building block 1 was education programs for older adults and their caregivers. Building block 2 was progressive exercise programs to improve mobility, strength, and balance. Building block 3, medication review and management. Building block 4, vision exams and improvement. And today's webinar is building block number 5, home safety assessment and home modification. And with that, my computer froze. I'd like to turn it over to Linda Underbrink to talk a little bit about the Foothills RETAC pilot project.
Are we going to move to the next screen?
I'd love to, Linda, but my computer screen is frozen. There you go.
Well, thanks, Karen, and just a clap of hands to Karen here. Karen is one of our co-chairs for the Foothills RETAC Injury Prevention Committee. Just a little bit about RETACs. As you guys, some of you might know, there are 11 RETACs in the state of Colorado, and we are charged with 15 different components of an EMTS system. One of those components, of course, is injury prevention. We do other things, lots of other things, like MCI planning, like research, CQI, system evaluation, to just name a few. But today we're going to concentrate on our injury prevention activities. And again, Karen is our co-chair. We have Karen Masters also from Lutheran Hospital, who is our other co-chair. And I got to tell you that it takes a group of doers in any organization to get things going. And Karen are definitely, I call them the Karens, are definitely our doers when it comes to injury prevention. They're very excited about injury prevention activities of all sorts. And so since this webinar was really to help organizations build their own community injury prevention activities, I can't stress enough how important it is within your little communities or any community, any group that you have that's interested in doing that, is you need that handful of people really interested and really excited about that. And so we're very lucky to have the Karens on board, and that's how we got started into this. A little bit next about how our project got started. 3 years ago, again with our Injury Prevention Committee within our RETAC, and our RETAC contains Boulder County, Clear Creek County, Gilpin County, Grand County, and Jefferson County. Now, for those of you who don't know those counties real well, that is an extremely diverse group of counties. We have everything from extremely rural frontier counties such as Grand County, down to Gilpin with the casinos and so forth in Blackhawk. And we also have I-70 corridor going up to the tunnel there out of Denver. Jefferson County, which contains Lutheran Hospital and St. Anthony's Hospital. And then, of course, the Republic of Boulder. We love them dearly. They have 4 trauma centers up there and an extremely active group up in Boulder. So, as you can see, we have an extremely diverse group of counties. So in order to tackle injury prevention activities within our RETAC, we felt like we needed to do some research, basically, to find out what our actual injuries were. So 3 years ago, we contracted with the CSU Research Department to perform a true analysis of what the injuries are within our RETAC. So they did an outstanding job and broke down our actual injuries, hospitalizations, and deaths within our RETAC by county and by age. So it was a surprise and yet not a surprise to find, because we all know this anecdotally, is that our 2 main causes of hospitalizations, injuries, and deaths were motor vehicle crashes and falls. So we decided within our RETAC group to concentrate on those 2. So for motor vehicle crashes, we contracted with DriveSmart, and through a wonderful partnership with CDOT, CDOT granted us funding for the last 2 years to attack motor vehicle crashes. So that's how we're handling that. For falls, that's where this comes in. For falls, we looked at what we could do as a RETAC to tackle the issue of falls. Falls in home, falls in other ways, what we could do. Now, understanding that a RETAC is mostly made up of all people from the continuum of care. So that's everything from dispatch to our pre-hospital providers, to our hospitals, to our rehab, all along the continuum of care for emergency medicine we have on our injury prevention group. So we thought, well, what could we do that included all of those branches in the continuum of care? So we thought, okay, with falls, maybe what we needed to do was to involve our pre-hospital community and our facilities and start there. So what we looked at was when a lot of our pre-hospital people that attend our committee said, you know, there's a lot of issues when they go into a home to pick up a patient, or maybe they're called for a lift assist or whatever. They are the primary people going into anybody's home. They see what they see. And a lot of times if you ask those pre-hospital people, what are you seeing in those homes? It's just amazing what you hear. One of the things that, of course, they bring up is the fall hazards that they are just seeing in their home, even without any training. They know that these are fall hazards. They know if somebody's oxygen tube is laid across the room. They know if the stairs are just narrow. They just know that this is a fall hazard. So we decided to start there. And so, Karen, could you change to the next slide? Within that group, what we did was we started a forum, and I think you can see it a little bit here. Now, we decided also when we were talking about falls was not to do just falls, because we would be missing an opportunity to notice other hazards and other problems within a home. So what we did was develop what we called our patient safety home environment referral form. Now this, as you can see, starts from the very beginning. What agency is it? Within the Foothills RETAC, we have 24 transporting agencies and 64 fire departments, 9 hospitals. So this was pretty huge when we talked about starting this. Members of our injury prevention committee, and especially pre-hospital, volunteered to pilot a program. So we developed this form here, and we started with falls. What are you seeing when you go into that home? They all have talked a lot about their frequent flyers, for instance, you know, and it may not be a good way to put it, but they may go into a home twice a week or 3 times a month because of something happening in a home. So there may be other issues than besides just falls. And we have a couple of speakers after me that will talk a little bit more about that. But we also wanted to take this chance to take a look at this and what else they could address. For instance, maybe there's a problem with the environment. Maybe it's just cold in there. Maybe they don't have heat. Maybe they don't have food in the refrigerator. Maybe they're saying that these people could use some help. Maybe they need a caregiver. What is needed in that home that would make their home life better? So besides falls, we wanted to open it up to that. So what we did was we talked to 6 of our pre-hospital providers to start our pilot program. And we talked to all 9 of our hospitals saying, okay, if you get this form, what are you going to do with it? It's up to the pre-hospital provider to fill out this form. If they transport, a copy of this form is given to the hospital that they transport that patient to. If they do not transport, they keep a copy of this and refer as needed and where to as needed. So, for instance, if it's a social services problem, they might go there. If it's a fall issue, they may call the fall prevention groups. Just depending on what the issue is, that's where they will refer if they did not transport. So, as you can see, there's 2 avenues here. It's if they transport and if they don't transport. This is then dropped off with the patient, and at that point, it's up to each of our hospitals, and each of our 9 hospitals develop their own process for what they would do with this form when they got it. Some of our hospitals are referring directly to their county social services. Some are, such as Jefferson, they will refer to the fall prevention group. Just depends on what they're seeing as to where this goes from here. We are in the process still of our pilot program, so we're having a little bit of difficulty getting all this together, especially with nursing staffs. You know how that goes. If they get this form and they didn't hear about it, you know, they're kind of wondering what to do, but those processes are getting cleaned up right now. That's why we have a 6-month pilot project. We may end up extending that depending on how many we receive during that time. But that's what's happening now. We felt like, as a region, that this was a good thing for us to do to tackle our actual injuries, illnesses, and hospitalizations. So if there's any questions about this, be sure and put them in at the end. We'd love to answer them. That's what we're doing as a RETAC. And RETACs, I think, are a very good place to start with something like this. You may have all of those groups in the continuum of care within your RETAC or within your area. So we just wanted to show you what we're doing, and I'd be glad to come back afterward and tell you how it went. But that's our part, and that's my part. Thank you all.
Thank you, Linda, for talking about that. Karen, did you want me to go ahead and talk about how we are utilizing the Foothills RETAC form?
Sure. You can take a minute to do that and then talk about what you're doing at Westminster Fire.
Okay. Hello, everyone. This is Tina Takahashi. I'm a Lieutenant EMS Field Coordinator with Westminster Fire Department. And we worked with the RETAC, both EMS and hospital staff, to develop the form, and I think that that was a really important component. We, Linda, I know you mentioned training at the hospital, but there's also been push for training at the ground level with the EMS crews.
what we have found in the past is that emergency medical services definitely have an insight into what's going on in a home, but often the message would get lost in the transfer of the patient. So this form is a great way for us to be able to capture some of that information and start the process and really work toward a continuum of care for the individuals that we're transporting. We are also utilizing the form internally at our department to address individuals who don't get transported, to be able to talk with them and see if there are services that we can refer them to. And we are also identifying our system abusers. And internally, we have developed a policy to deal with those type of situations. So the form has been great for us. It's been slow to start, as is anything new. A change in the fire service tends to take a while to catch on. But the more forms that we receive and the more that we remind crews why it's there and what it's for, I think the better we will be at being able to address the needs of our patients in the future. So, Karen, did you want more discussion on the form, or did you want me to?
Tina?
Yeah.
Oh, I'll just go ahead. I'm going to put your form up that you're using at Westminster Fire for your home assessment.
Okay, great.
If you want to talk about that for just a minute.
Absolutely.
Thank you.
Sure.
There we go. Okay, can you see that?
Yep, I sure can.
Okay, so I'll use.
Wonderful, thank you. So at Westminster Fire Department, we applied for a grant from the Department of Homeland Security, and this was in January of 2007, and we were able to run this program with grant funding for approximately a year. And our target audience was high-risk, low-income seniors, and our goal was home safety checks, placement of smoke detectors, carbon monoxide detectors, installation of NOx boxes if necessary, and installation and provision of other home safety equipment if needed and available. The grant funding itself allowed for actually some really great items to be able to take with us. We were able to hand out smoke detectors and carbon monoxide detectors. We were also able to deal with the injury prevention component with non-slip mats in the showers and bathtubs, night lights so that pathways within the home were lit at night, of course, when it was needed. We also utilized this opportunity to review file of life information for the homes that we went into. And one of the things that we learned in starting this process was once we were getting into the homes, we noticed that we had a lot of burn injuries that were happening in the kitchen. So it helped us to address some of those issues as well and be able to hand out cooking mitts and kind of zone in on being able to talk about safety in the kitchen. So the form itself is divided by room, and we tried to make it an educational experience by reviewing some educational components with the individuals as we would go through each room. The program was a great success, and once the funding of the program was gone, we had to look internally at how to keep the program alive. And what we do now is we have 1 day a quarter set up for individuals to register, and we send a firefighter and a volunteer. And our volunteers come from our Citizens Academy alumni. And we have trained them and would ultimately like to turn this program over to the Citizens Academy alumni, but as of this date, we're still working on training, and we want to be sure that they're comfortable before that happens. So once a quarter, it's an all-day, typically probably a 10, 12-hour day for the firefighter and the volunteer due to the number of requests that we have. And that's how our home safety program works at this time. We don't have a lot of the handouts that the initial program granted, but we're definitely able to hook people up. Lowe's and Home Depot have been extremely helpful in their smoke detector and carbon monoxide alarm, assisting us with being able to purchase those and or granting those to us as a fire department. So it's very successful. It's a great way to build your community. Having the firefighters there, I think, is an integral part at this point. From a fire standpoint, we're able to get into these homes and see the layout, and if there are issues or add-ons to the home or anything that would be a fire hazard, we can address those with the homeowners and make recommendations. And as far as the safety issues, as you can go through and see on the form, we really try to address those issues that are pertinent and can lead to either fires or injuries. So that's how our program works right now. And if you have any questions, please feel free to either send them here at the webinar, or you can contact me at Westminster Fire Department. Thank you.
Hello, this is Sherry Cabrera now. I am an occupational therapist. I specialize in home modifications and fall prevention. And I am going to talk a little bit more about an overview of what home modifications is, the kind of theories and models behind evaluating the home, and give an example of a home evaluation process. So the first thing I'd like to start with is evidence-based practice in home modifications and fall prevention. And I want to give this overview just to kind of have us think about the research that's out there and what's working with home modifications and what some of the barriers are with home modifications, and specifically for preventing falls in the home or injuries in the home. So the first research I want to talk about is a study that evaluated the cost effectiveness of fall prevention programs that reduce fall-related hip fractures in older adults. So this was pretty specific. It was looking at the reduction of fall-related hip fractures, and they were looking at several different interventions that can be used for fall prevention, such as medication management, exercise and strengthening programs, and home modifications was one of those as well. So of the more studied interventions, they found that home modifications provided the best value and the highest economic benefit over the lifetime. So in essence, you may have a more of an upfront cost with that home modification, but when they looked at it over a lifetime, it had the highest economic benefit and was the most cost effective. So then the next one I want to talk about is looking at, it was also a systematic review of the effects of home modifications and fall prevention programs on falls and the performance of community dwelling older adults. So this is a pretty recent study done in 2012, and they found that the strongest results were found for multifactorial programs that included home evaluations, home modifications, physical activity or exercise, education, vision and medication checks, and assistive technology to prevent falls. So I don't think this is anything new to any of us. We know that falls are multifactorial, so having that multifactorial approach is really important, and this research just supports that. The positive outcomes included a decreased rate of functional decline, a decrease in fear of falling, and an increase in physical factors such as balance and strength, is where their indicators were. And I have references at the end of the slideshow. So if you want more information on these, I can get it to you certainly, but as well, but there are references at the end as well you can look at. So the next couple slides are looking more at what are the barriers or the challenges we have with using home modifications as an intervention for fall prevention. So the next study looked at adherence to occupational therapist recommendations for home modifications for fall prevention. And a major barrier to adherence they found for the home modifications recommendations is that many older people do not believe that home modifications can reduce their risk of falling. So I think this is a big one. I mean, it really, and I'm going to talk about it more when we're talking about the evaluation process, but it goes into how important using a client-centered approach is, and really having that buy-in from the homeowner is important in making sure that these modifications and equipment we're giving to these people are really impacting their life at home and increasing the safety. So the last study I have to talk about is a study that I helped collect data for with the Broomfield Injury Prevention and Independent Living Program. And we collected data from 2005 until 2010, and it was a little under 400 participants. So we had a pretty good number of participants, and we had collected most of the data from follow-up. So we have follow-up phone calls, follow-up questionnaires at 3 months, 6 months, and a year to collect this information. And then I collaborated with the CSU Occupational Therapy Department, who did a wonderful job of putting all this data together and looking at it. And so our intent was to explore the relationships between the adherence of fall prevention recommendations and the client's characteristics possibly related to adherence. So it's also looking at adherence. We're going a little bit deeper into it now. So what we found was adherence and increased self-rated fall prevention knowledge was correlated only in a subgroup of participants who identified helpful attributes to recommendations in their narrative responses. So I think this is really telling with using the client-centered approach and making sure you have that educational component, making sure that you have that buy-in, and participants verbalizing positive aspects of following the home modification suggests that an understanding of the benefit may be associated with the adherence to the recommendations and the use of the home modifications. So I think this is really telling how we need to approach home modifications when we're going to make these recommendations. So next I'm going to do just a brief overview of defining what home modifications really is, and then talking a little bit more about kind of the theories and models behind how we evaluate that environment. So home modifications are adaptations to living environments intended to increase the usage or usability, safety, security, and independence for the user. I like this definition. And then home modifications, and I'm going to talk about this a little bit more on the next slide too, are used in conjunction with assistive devices often and client-centered training. And client-centered training is a really important piece here. And also you have to think about home modifications as being a process. So it's a process where you're evaluating the needs, identifying and implementing those solutions, followed up by the training, so the participant or the homeowner knows how to use this equipment or the modifications that were made, and also very important is evaluating those outcomes to make sure that we are making a difference. So what are home modification interventions? So I included this slide because I really think it's important to look, when we're going in to do home modifications, it's really important to look at it as a global thought process. So I'm not just going in and looking solely at the environment and seeing, making those environmental modifications to decide what's best in that area. I'm really, there's many different things that you have to take into consideration and many different solutions you have to take into consideration. So, of course, adaptive equipment is one. Architectural modifications are traditional things that we think of as being a home modification, putting in a roll-in shower, adding grab bars, using a bath bench or a raised toilet seat. The other things I think you really can't exclude are task modification, because a lot of times you may be doing an environmental modification and or giving them equipment, but it's really important also to make sure that that there's options where they may be able to change how they're doing something to make it work better for them. So an example of that might be somebody with COPD that has poor endurance, and we might change where we have things in the kitchen or make some modifications, but an important piece of it might be energy conservation techniques and work simplification techniques that you're teaching them. And the other component, another one, is personal assistance. So that always can be a component of a home modification because, one, a person may need a home modification, but they still may need to be dependent on a caregiver to help them with that. So that needs to be part of the process and the solution. Or they may choose to have personal assistance instead of using a home modification. So you need to think about those options. Of course, the patient and caregiver education is really important because this is a big component. You have to have that for the buy-in and for them to really truly understand the benefits of using home modifications to increase their safety and independence in the home. And the other key thing is referrals to appropriate community resources. It's really important not to forget that that could be a component to it as well. You might have somebody who's not able to do meal preparation in the home, and you can certainly make a modification so they can access the kitchen better and use the kitchen and become more independent. But another solution may also be using a community resource as simple as Meals on Wheels or a combination of the two. So that's why I put that slide in here, because it's so important to think about that. And the next thing I want to talk about is evaluating the environment. So how do we go about evaluating that environment and making recommendations for home modifications? So what are the tools for evaluating the environment? And I'm not going to talk a lot about this. I want to just give a couple examples of different things that we can use. And we've already talked about safety checklists today that Tina talked about hers. And using these is a great method for screening for potential problem areas or safety concerns in the home. We really want to identify what are those problem areas, what are the safety concerns in the home. There's many different safety checklists out there, and it's a great tool and a great way to identify these problems. And it's great because anybody can administer a safety checklist, and there are also safety checklists out there that are self-administered by the homeowner themselves. So it's a really great tool that can be used in many different settings. So how does that differ from a standardized home evaluation tool? So the standardized home evaluation tool is going to provide a comprehensive evaluation of the home environment and the barriers to occupational performance. So you're going a little more in depth there and really looking at how that person is interacting with their environment, and is it supporting their occupational performance or not. And I just listed a few of the standardized tools that are out there. The Safer Home is one, the Enabler is one. I'm not going to talk about all of these. My next few slides are going to talk a little bit about the Canadian Occupational Performance Measure, but more so it's a model that we use for our thought process when we're going into the home and looking at the environment. And also I'm going to highlight the in-home occupational performance evaluation, the IHOPE, to give you an example of what a standardized tool looks like and all the steps that you go through when using one. And I like that one. I'm going to use it as an example just because it's very client-centered and it really details all the steps that you go through. So before we get into that, I want to just define what is a client-centered approach, because this is a very key aspect to home modifications and making sure that you're making a difference.
So client-centered approach to environmental modifications builds on an alliance between the client and the home modifications team to use their combined skills and strengths to work towards client goals related to occupational performance, and making sure that the client or the homeowner is the center of this process and an integral part of this process. So what is our thought process when we're going into the home, and what are some of the models that we use to evaluate the home? The Canadian Occupational Performance Model is a common one that we use when we're looking at the environment and making modifications. And it's looking at the person, the environment, and the occupation interactions, where the PEO fits. And I love this diagram because it really shows how they're layered together and intertwined, and you really can't separate any of them out. And what we're really looking at is the interactions between all of those, not anything separately. So I'm not, just looking at the environment by itself and just looking at the physical limitations the person may have. I'm looking at everything and how it interacts. So the environment can include the physical environment. It can include social, cultural, and institutional components. The occupations can be self-care. They can be leisure. It might be very important that they're able to do a leisure activity that they want to do, and it can be productive occupations as well. And when looking at the person, we're looking at not just their physical limitations, but the psychosocial component and also any cognitive impairments that may interfere with their occupational performance. So this is another diagram I like, and it's looking at maximizing occupational performance through changes in that PEO, or the person, environment, and occupation fit. So we're going in and identifying occupational strengths and problems and occupational performance. So in some, like the Canadian Occupational Performance Measure, it's an interview process that you just go through with a client. It's client-centered. They're leading the conversation and helping to identify what those problem areas are. You're going to assess the performance components. You're going to assess the occupation and activities and tasks, and assess the environmental conditions. But more importantly, you're going to bring this information together in a transactional framework, or look at how they really interact to develop intervention plan with that client. And the outcome is evaluated by measuring what that person's occupational performance is. So the diagram on the right I really like, because it's showing the person, environment, occupation, and how they overlap and they're intertwined. And when you have a higher or a larger overlap or a higher congruence of those, you're going to have an increase in occupational performance. And when you have less overlap or less congruence in those areas, you're going to have a decline in occupational performance. So the last thing I want to go into is talking a little bit more about an example of a standardized home evaluation tool. And I'm going to use the IHOPE for that. It was developed by Susan Stark and Emily Somerville of Washington University School of Medicine Program in Occupational Therapy. And they did a great job developing this, because they really took it to heart to make it client-centered. And I love this tool because it really makes you keep it client-centered. And sometimes that's hard when you're using the interview process and making sure that they're giving you all their input that they can. And so it kind of does a good job of bringing all of that out. So the purpose of the IHOPE is to identify performance issues in the home. And what they found was older adults underreport the presence of barriers in their home typically. So, and I think I always say, put it this way, because all of us as humans, we adapt to our environment. We always say, oh, I'm getting by, it's just fine. And you see that a lot in older adults in the home. And they don't think of it as a barrier, because guess what? They've been getting by. It's been working. So it's difficult for them to identify what those barriers are in the home. And then they also identify that interview strategies may not be sufficient to determine the problems. And practicing in this area and using other tools that use an interview process, I believe this is true, because oftentimes you'll be in the home working with somebody, you go through the whole interview process, you take your time, you really let them tell you what the problems are in the home, and you process through that with them. And then you go to the part of looking around at the environment and what they're doing with the environment and what's not working, and all this, and they go, oh, well, I didn't even tell you that I can't get in and out of bed. something like that, or this is difficult. So the iHope does a really good job of helping you get through this process. So there's a mismatch between older adults' ability and the environmental status and the barriers. And what iHope does is it matches that environmental support to prevent unnecessary functional loss or occupational performance is what it's looking at. So what are the steps for the iHope? So the first step when you're going into the home is it uses a card sort, which I think is a great way to really get that client or the homeowner as an integral part of this process. So these 44 cards are all different daily activities that they may be doing during the day. It could be taking medications, it could be getting in and out of the shower, it could be meal preparation, getting the mail. They even have ironing on there, which I probably wouldn't be doing, but some people might. So it has just a good array of all different kinds of daily tasks that people do. And they're going to sort them into piles. So they're going to sort it into I do not do and do not want to do. So this is very client-centered. So this isn't important to them. They don't want to do it. So you automatically can discard it. And then I do now with no problem. So they feel confident in that area. They don't need help with that. And the next is I do now with difficulty. So this is an area, one of the cards you're going to look at. I do now, but I'm worried about my ability to do in the future. So you're going to look at this. And I like this question as well, or this category they can sort it in, because it makes them think about, ooh, well, yeah, I am a little worried about doing that in the future. And I do not do, but want to do. So after they sort the cards, then you're going to prioritize those that they put into piles 3, 4, and 5. I do now with difficulty. I do now, but I'm worried about my ability in the future. And I do not do, but want to do. So now we're going to prioritize them and help them. They need to really figure out what's most important to them. What do they really want to do? And so that's the next step that you're going to take with it, with this. And then they're going to rate their performance after they do that. And so I really like this part because rating the performance, they're going to put it on a scale from 1, unable to perform, to 5, able to perform. So it kind of gives you their perception of how they're doing in the home. And then their satisfaction with that. And I love this part, the satisfaction, because not only is it just looking at their performance, but it's looking at how satisfied are they with that. So 1, not satisfied with the performance at all, to totally satisfied with the performance. And so this is also very client-centered. So it's making you think about what's important to them. So they might have something that they're not performing well or unable to do, but they're satisfied with that. So that's going to help them prioritize that. So maybe you're going to move it down lower to the bottom if they're satisfied with how they're doing with that right now. And then the next step is where you're identifying the barriers and determining that influence on the performance. So this is where the occupational therapist or the healthcare provider is really using their expertise to go through the home with the person, have them actually do mock performances of those activities, daily living or occupations that they identified as being problems, and having them show you how they're doing it and looking at that environment and seeing what's working and what's not working for that person in the environment. And with this step, they're also going to rate the barriers as you go through the home. And this is a process where the therapist and the homeowners is working, doing this together, and rating how much help are they needing with these activities because of the environmental barrier in the home. So no activity because of the barrier, all the way up to independent. It could be standby assist or maximum assistance that they're needing, and you do this together, helping that client identify what level they're at. And I like this slide because it really shows how the iHope is, instead of, especially from a traditional healthcare setting, from a therapist perspective, typically we're looking at what are the physical limitations or the barriers for that person. So instead of saying the shelf is too high, we're saying that their range of motion is decreased, and that's keeping them from reaching something on the shelf, or that their balance is decreased, or their lower extremity strength is poor, and that's keeping them from standing up from the toilet. But instead of looking at it that way, we're going to identify what those barriers are, and you're going to have item out of range or reach, and the shelves are too high in the kitchen for them to reach it. So it's the environment that you're going to modify and change to meet the limitations that that person has. Or the clothes dryers are too low to retrieve the clothes, or there's no hand supports near the toilet or near the shower, and no arms on a chair to push up from sit to stand. And so that's the process of what you're doing when you're in the home with the person, going through the I-HOPE part of the home evaluation process, identifying the occupational performance problems and the barriers in the home. And then you can also score the I-HOPE, and I love that about the I-HOPE. Because the scoring provides us with that before and after data to show that it's really making a difference. And I think that's really important if we're using home modifications, that we can show that this is making a difference with that person's performance. So when you score the I-HOPE, there's an activity score, a performance score, and a satisfaction score. And I'm not going to go into a lot of detail about this, but then you calculate those and you come up with a total barrier severity score. And that's the score you can use to really show that outcome, that it's making a difference. So you want to see a decrease in that total barrier severity score. So when making those recommendations for the client, so now we've identified the problem areas and identified the barriers in the home. What do we do next when we're making those recommendations? So ideally we want to provide 3 different solutions for each identified problem area or environmental barrier in the home. And this is really an important part of it, I think, because one, it gives that homeowner options. It keeps it client-centered. They get to choose what's going to work best for them. And I think we can all say that we like to have options. Even when we're going shopping and we're looking for blenders or whatever it might be, you like to have different options so you can pick the one that fits you best. It's the same way with home modifications. You want them to be able to pick the one that fits them best. And the other really important reason for giving these options is because a lot of the people we're working with are on fixed incomes, and they're going to have to possibly choose from different options depending on what their budget is. So you can give options that are a lower tech, lower cost option, such as a piece of adaptive equipment, to putting a roll-in shower in. So it gives them those options as well. And then you want to offer the pros and cons for each of these solutions. So when you're talking about, okay, you can use a lower cost option, then you can talk about the cons. That maybe that might have to be changed in the future. And then you need, of course, again, to prioritize the solutions with the homeowner and the home modifications team using the client. They're the one who's really going to determine what's most important for them right now. And this is because of those financial considerations as well. So when they're going through the process, they are able to say, this is most important and this is at the top of my list right now, and this maybe isn't as important. So I think that is all of my slides, and I'm going to hand this off to Kenna now, and she's going to talk a little bit more about specific home modifications and also talk about that home modification team and the importance of that. So thank you so much for having me today, and I'm going to pass this on.
Hello. I hope can you hear me? This is Kenna Quiller with Hudson Integrative Health Plus Homes. Are we on? Hello. This is Kenna Quiller with Hudson Integrative Health Plus Homes, and we have an integrated approach of linking personal health and home environment. So the first slide, where's our slide? so it's all the way back to her. 1 minute, we'll get the slide up. What we'd like to do now, while we're getting to the correct slide, is we'd like to discuss home modification from the builder, contractor, architect, and kitchen and bath design perspective as a team member with the homeowner, family, and the healthcare professional. So what we're looking at here is the value of the team approach to home modification. Firstly, we believe, and as Sherry has mentioned, in the person-centered focus. It's a collaboration that ensures that the recommendations are carried out according to the client's goals and desires. That's a very critical element and piece in making sure that whatever modifications are done is suitable to the individual. No two people are alike, nor do they have the same needs. The second is the linked assessments. From specific feedback from the occupational therapist, any modification requirements are reviewed by a certified aging in place specialist, who would be us, who would assess the structural integrity and ensure that all modifications meet or exceed all the building codes and that we're mindful of the budgets of the individual. Throughout this process will be good communication. The home modification projects involve many details, and verbal and written communication between all stakeholders is vital. And linking those assessments and the communication process have everything to do with what Sherry mentioned with the educational component. Really critical to keep that component involved in this process. Then lastly, to follow up after completion to ensure modifications meet the client's needs. Assisting our clients in living a healthy life in a safe environment is our collective goal as we go through this process. So let's take a look at the most common modification solutions. And this is as stated in research from the National Association of Home Builders. As you can see here, grab bars are the #1 modification solution. Then higher toilets, curbless showers, wider doorways, ramps and lower thresholds, lighting and task lighting, and then main level bedroom, which is literally moving the bedroom or readjusting the main bedroom to the main level of the home. And let's take a look at just a few examples here. In the upper right-hand corner, we have the shower bench, which is the most economical means by which to make it possible to be able to access the shower over that step by sitting down first. The left-hand side shows the low threshold shower with grab bars, which allows wheelchair access with minimal ramp to negotiate. Obviously, the bottom right is the ideal, absolutely barrier-free, which is the no threshold shower. This next page, we show assisted devices, and you can see the ones that are retrofit. The upper left, the upper right, and the lower left are an example of the lower right are examples of retrofits. And then on the lower left is the Comfort Height toilet and grab bars. And the Comfort Height toilet is 1.5 inches higher than a normal size toilet, so it does create more ease with usage. On this next slide, on the upper right, it shows an example of the cutout to an existing tub. There's a sizable step up of 4 inches, but it does allow access to the shower without extensive remodeling. On the left-hand side is the low threshold walk-in tub that you can see, and lower right is the top view of the tub with the grab bar inside. So there are options available depending on what the assessments and the recommendations might be. Next, we have 2 examples of ramp options. And the one on the left is the site-built wooden ramp, which allows 2 egress options. One is the stairs, as you can see, and the other one is the ramp. The temporary aluminum ramp can be built to look permanent, but on the right you can see there an example of the temporary ramp. I want to speak just for a moment here about universal design. Homes are being built, modified, and remodeled using universal design principles. And what they are is a design focused on living comfortably, effortlessly, and safely in the same structure for a lifetime by creating aesthetically pleasing and accessible environments. The 4 keys of universal design are, number 1, ease of use. Number 2, getting around, designing to accommodate the needs of people who use mobility aids. Number 3 is flexibility, adaptable interior features that allows users a customized fit both now and any future needs that they might have. And then safe, healthy living. It can reduce the risk of accidents, including falls. It is designed for the largest achievable segment of the population for all ages and all stages, whether temporary, permanent, or progressive needs are involved. So let's take a minute here to look at some examples of effective universal design. On the left, you'll see number 1, which are removable cabinets for wheelchair access. So they can be built for today's use, but also be readily available for any future needs. Number 2 is an example of wheelchair accessible kitchen counters, and you can also see some specialized task lighting that's been added to help with seeing what's on the counter and where all your work material is. Number 3 is an example of the raised washer and dryer, which allows for you to be able to be upright. You don't need to stoop and bend to use it, and it is wheelchair accessible as well. Number 4 is a no threshold entry. And 5 is really slick. It's pull-down cabinets, shelving that makes it easily accessible to see what's on the shelf, which allows ease of use of these shelving. Number 6 is probably the most simple home modification that you can do with the biggest impact, and that is door levers, which allow for ease of use without having to grip a handle. And the bottom picture, number 7, is wide doorways with a single level living space. And you can see the natural lighting and the additional lighting that's been added into this space. But this just gives you some examples of what can be accomplished to modify the home environment. Now, Sherry had mentioned about working together as a team, so we wanted to give you today some examples of selecting a building partner. We believe certified aging in place specialists, and those are called CAP specialists, is an important part of any kind of modification because they are certified in unique age-related needs, which include lifestyle, health, and family living situations. Being a member of a recognized association such as the National Association of Home Builders, strong work history and experience in the building industry, holding a current general contractor's license, maintain appropriate insurance coverage, and offer competitive bid and work guarantee. So we believe those are an important part of the team concept with this. The goal of age-in-place remodeling is the ability to remodel while living in your home. This is another advantage of using a CAP-certified builder because they work with the homeowner to be able to make any changes that need to happen while they're still existing in the home. The goals of this is to protect safety and privacy. The contractor would take precautions for both safety and privacy considerations, to consider regular routines of the homeowner to make sure that they're not interfering with what those routines need to be, and develop a plan and protocol to communicate and work with a timeline throughout the project and have communication with all team members and on-site work crews. So those are really important concepts when you're looking at home modification for aging in place population. The advantages of modification to the home environment would also include improving individual safety and mobility, increased usability of the home environment, to promote independence by eliminating environmental barriers, to prepare for future needs with adaptable modification, increase home value by incorporating universal design, which are usable by all people in all stages of life, and to avoid the monthly expense associated with assisted living communities. And of course, what we have too is to show you what we believe is the winning formula for remaining safe and independent at home while increasing overall health and well-being is best accomplished by partnering through the team approach, linking the assessments from the occupational therapist and the builder, identifying home modification solutions, implementing those solutions, and then complete follow-up and follow-through to making sure that these are meeting the needs of the client. The prevention of falls is an essential aspect of improving safety and mobility, and many falls are related to home environment hazards. Many of these hazards can be minimized or eliminated during the home modification process. So I think what we have one more slide just for contact information for Sherry and myself. And I know we've kind of come up to the end of our time, but we would be available if anybody wants to contact us directly with any questions or comments regarding the presentation. Thank you.
Okay, thank you to all of our presenters today. We will now open the question and answer session. So I will start opening up the phone lines. We did get a couple questions that came across, so we will just start with those. The first being for Linda regarding the referral form. Who was your contact at the hospitals to develop this process of follow-through?
Well, I'll tell you, almost to a one, it was our trauma coordinators that we started with. I do believe every one of our 9 trauma coordinators also on our injury prevention committee. I hear noise. I hope you guys aren't hearing it too bad. Anyway, so our trauma coordinators each went back to their own facilities to see how this would work within their group. So, for instance, I believe Karen got together with her ER nurses and with their referrals anywhere in there, their social services departments, and each hospital individually figured out what would work within their hospital. But we started with trauma coordinators.
Okay, and also about the same form, can you please post the referral form on the Falls website or send it via email?
I will certainly send it via email to you, and you can post whatever you'd like. Now, understanding that this is a pilot program, it may have some modifications to this form after we find what worked and what didn't. We may modify that.
Okay, so we will get that form to Janet, and if anybody else is interested, please contact one of us. And the next question is for Tina. How did you enroll folks in your pilot in 2007? Were they folks who had fallen or folks who had volunteered for a home visit?
They were individuals that had volunteered. Once we started, it was really by word of mouth that we started the program, and it became very popular very quickly.
Okay, thank you. And then for Sherry, do you have grant or funding for the IHOPE recommendations for older adults to make the environmental changes?
No. So the IHOPE is just a standardized evaluation tool that we use to evaluate the home, not grant funded in any way.
Okay. Is there a website to find more information on IHOPE?
I can get that to you, and yes, I can get it to you, so then you can post that. Will that work?
Great, that would be great. So we will get that on the Older Adult Falls website, and Janet, I will also get that to you in a direct email. And the last question that I have here is, how do you do OT liability coverage for home assessments and billing?
So it would be covered under our professional liability insurance, and then a general insurance as well, like all that umbrella kind of policy as well for liability. And for and on an outpatient service basis is actually how you would bill it. Now, if home health is involved, it can be billed through Part A Medicare as well, through a home health therapist. And any OT can use this evaluation. So even if their therapist in rehab could come out into the home and do it that way as well.
Okay, are there any other questions from the phone? All right, well, thank you all for joining us today, and we look forward to seeing you in 2 weeks.